Statins are the most commonly prescribed drug in the NHS, but they may also be one of the most controversial drugs we use. This controversy can come from misleading articles that pop up in the news or social media, but there's also an extensive debate in the scientific community about how we should be using these drugs. This debate shouldn't be a concern, as it's exactly what we want to happen for any drug that's widely used in our society, but it can sometimes make it difficult to know where the balance of evidence lies. Statins were marketed as a cholesterol-lowering drug, but they're actually more effective than any other cholesterol-lowering drug at preventing the things that really matter, which are heart attacks, strokes, and amputation in peripheral vascular disease. We didn't know why statins were more effective until recently, but statins actually have some anti-inflammatory effects which keep the lining of the blood vessels healthy. These are dose-dependent effects, so high-intensity statins give us a better level of protection, and that's what's recommended in our guidance. Figuring out which statins and doses of them are high intensity can be tricky, but in practice we really only have two first-line options. If you've recently had a heart attack, it's atorvastatin 80 mg, and for everyone else it's atorvastatin 20 mg. Before starting, you'll check lipids and liver function at baseline, and these tests are both repeated at 3 months and 12 months after starting. These tests are a great opportunity to check if we've hit the targets for the bad cholesterol, which is called LDL or non-HDL. We're trying to reduce this by 40% from baseline for primary prevention, or hit an LDL of 2 or less, or a non-HDL of 2.6 or less for secondary prevention. If the liver function's checked too soon, the enzymes are falsely elevated by a process called transaminitis. This happens with all cholesterol-lowering treatments and is self-limiting, so don't be alarmed if there's a small rise in liver enzymes here, but you will need to investigate these abnormal results to rule out any non-statin causes. NICE have some excellent guidance on managing statin-related side effects, and if people have problems with atorvastatin, the second-line option would be Rosuvastatin. This is useful because it's water-soluble, and this makes it less likely to reach deep tissues in the central nervous system, and this makes it less likely to cause side effects as a result. There's some unique interactions with Rosuvastatin and ethnicity considerations too, as certain East Asian patients could double their exposure to Rosuvastatin, so as a precaution I generally start with 5 mg and build up, and I only start higher than that if someone's recently had a heart attack or stroke. As a third-line option, I generally use pravastatin. This is probably the mildest statin in terms of side effects, but it's also the weakest statin in terms of cholesterol lowering, and the biggest problem with pravastatin is it probably won't be enough to get the lipids under control on its own. While statins are a really important drug for preventing cardiovascular disease, they sit alongside a brilliant range of interventions and steps to improve someone's well-being, which all help to lower someone's risk of these events. Conversations you have about statins are a perfect chance to explore these further, so don't miss this opportunity when it comes by.